Hi, everyone. I'm very happy to have my colleague, Dr. Adrienne Strong, who is a faculty member in anthropology and an affiliate of the Center for African Studies here at the University of Florida. She's been at UF since 2018 and holds a PhD in anthropology from Washington University, St. Louis. Soon after she completed her PhD, she held a postdoctoral fellowship at Columbia's Mailman School of Public Health, and with support from the National Science Foundation, she returned to Tanzania to conduct further research on her specialty, which is women's health, especially maternity and childbirth, and the experiences of healthcare workers and the nature of healthcare facilities in Africa. She's published extensively in journals such as Human Organization, Social Science and Medicine, and a number of edited volumes. She has her new book just out. A big congratulations on that. It's entitled Documenting Death, Maternal Mortality and the Ethics of Care in Tanzania, published by University of California Press. Her talk today will be of the same title as this book, and I'm very much looking forward to hearing about her extensive research on women's health and childbirth in Tanzania. Thanks so much for joining us and sharing your work today.
Thanks, Brenda and Todd. I'm set to take it away, right? I can share my screen and everything? Okay.
You should be able to, yes.
Yeah, looks good. So as Brenda mentioned, my book just came out last week, and I will tell you a little bit about that and then share an excerpt from one of the middle chapters, sort of as a teaser, and also to highlight some of the themes in the book and share a few of the stories from that. So we will go ahead and get started. Also, I just want to mention the book is open access, which means that the digital versions of it are all free to download. So this book has its roots in events that happened well before I knew what medical anthropology was, and certainly long before I had any intention of getting a PhD, let alone writing an actual book. I was 19 years old and standing in what amounted to the autopsy room at the Singida Regional Referral Hospital in Tanzania. It was my second trip to the country, and honestly, it still strikes me as slightly mad that my parents even agreed to let me go that second time. I didn't go as any part of a program or organized trip, just with two other undergrads I'd met the year before in Tanzania and a couple of their friends. I'd ended up in the autopsy room with two of these fellow American students and one of the Tanzanian physicians. Dr. Godfrey was assigned to the maternity ward and frequently let us trail around the hospital in his wake. When he'd asked if we wanted to watch the autopsy, we all somewhat hesitantly said yes. We were, after all, overly eager pre-meds, hoping to learn as much as we could. The autopsy was of a woman who had died during labor. Her full-term baby had also not survived. As Dr. Godfrey made the first incision, just like I'd watched him make for C-sections, a procedure that might have saved the woman and her baby, I was struck by the global inequities that had brought us all to that moment. In the world at large, we have the knowledge and resources to prevent the deaths of women during pregnancy. So I began to wonder what other factors had made it so that this woman, and many others like her each and every year, continue to die of pregnancy-related causes. And this is a central question that I've been pursuing ever since. Documenting Death, the book, is my attempt to answer the two questions you see here. With more than 30 years of investment in decreasing maternal mortality, why are countries like Tanzania still struggling to make significant improvements? And is there something about hospitals as bureaucracies and as social environments that might be hindering further declines in maternal deaths, as counterintuitive as this might seem? So first, there is a problem, maternal death. And then I have to introduce you to the hospital. And then after that, we're ready to jump into the subjects at hand. So after these bits of introduction, I'm going to spend the rest of the talk focusing on just one part of the book, maternal death audit meetings. Since the start of the Safe Motherhood Initiative in 1985, there have been enormous global efforts to reduce maternal deaths. The Millennium Development Goals, or MDGs, included reducing maternal mortality by 3/4 from the 1990 level by the end of 2015. Though a number of countries have made significant progress in reducing deaths from pregnancy-related causes, almost 300,000 women still die globally each year. Tanzania has achieved almost no sustained change in the maternal mortality ratio, the most common indicator used to report maternal deaths as the number of deaths per 100,000 live births. These deaths of women due to pregnancy-related causes occur in Tanzania and in many other countries, both inside and outside health facilities. Here in this map, you can see the world's land area redistributed in proportion to the number of maternal deaths in every country. The arrow is pointing there to Tanzania, and you can see that Sub-Saharan Africa and South Asia definitely still bear the outsized burden of these deaths globally. I first visited what I call Mawingu Regional Referral Hospital in 2012. The hospital is located in the Rukwa region in the southwest corner of Tanzania, and there in the map, it's in the dark green spot with the surrounding area, the whole region. The hospital serves a catchment area of more than 1 million people. The town in which the hospital is located, Sumbawanga, is high on the Ufipa Plateau. The region's remote location meant that for many years it was poorly connected to the rest of the country. That, combined with its reputation as a home to powerful healers and witches, meant it was extremely difficult to retain highly qualified healthcare professionals. The entire time I worked at Mawingu, the hospital was understaffed and constantly struggling financially to make ends meet. Despite these difficulties, the staff members had succeeded in slowly improving the reputation of the hospital and patient outcomes. For instance, in maternity care, they had instituted new protocols in 2011 that significantly reduced the number of postoperative infections for women who had had C-sections. The majority of the work for my book occurred during more than 20 months of field work in 2014 and 15. I spent much of that time at Mawingu on the maternity ward, which you see some pictures of here. The largest and busiest ward at the hospital, the ward's 3 doctors, none of whom were obstetricians, and approximately 20 nurse midwives delivered between 450 and 600 babies per month. Over the course of my time at Mawingu, it was impossible to ignore the increasing documentation requirements, signs of growing bureaucracy, as the hospital administration, the Ministry of Health, and various NGOs told the nurses to keep track of everything from how many pairs of gloves they used caring for each patient to the number of HIV tests that each staff member carried out on patients each month. The growing stack of notebooks and registers on the nursing desk was a visible measure of the growing bureaucracy within the hospital that followed when new accounting systems arrived, for instance, or when new programs for improving management of postpartum hemorrhage were rolled out. And this picture is actually from 2016 when I returned, and the stack had sort of grown by 1/3, all of these notebooks. Another part of the hospital and maternity ward bureaucracy was the maternal death audit meeting. In addition to a bureaucratic requirement, these audit meetings were a formal government-mandated accountability mechanism, one that linked individual deaths in healthcare workers with their institution, the region, and the rest of the country. The Ministry of Health requires audits of all maternal deaths, as well as neonatal deaths and stillbirths, though the latter 2 audits never occurred while I was at Mawingu. I concentrate on the maternal death audit meetings to examine not only documentation and data or accountability, but also the discourse that took shape in discussions about women's deaths that resulted from the audit and the roles these had in shaping responsibility for maternal deaths. The audit meetings became a bureaucratic technology and a tool of reproductive governance that, in opposition to their planned purpose, worked to normalize poor reporting and the number of deaths that occurred in the region. I first observed a maternal death audit meeting in 2013 while conducting a pilot study at Mawingu. I have since participated in 3 others. Though these meetings are supposed to take place minimally once per quarter, in reality, they took place much less frequently. In this picture here, you can see all of the files to be discussed in a meeting in July 2014. In addition to deaths from 2014, there were also several from the end of 2013 that had never been reviewed. By the time the maternity ward doctor in charge had called the meeting and notified all the appropriate district and regional level administrators, the details of each woman's case were long forgotten, turned into an indistinct blur by the passing of time. No two women's deaths followed the same trajectory, making each case unique, but with all too common underlying similarities. It was these commonalities that the death audit system was designed to pick up on and turn into action plans and points of intervention. In this way, the idea goes, no death is in vain. Each woman leaves behind lessons that can be carried forward to prevent the death of another. In these meetings, the discussion of a case always ended with the same question: was this death preventable? 9 times out of 10, the answer was yes, this death was preventable. What varied vastly between deaths was how the death occurred, what transpired on the woman's slow or rapid road to death, and who was ultimately responsible for ensuring that such a death would not happen again in the future. In Tanzania, the Ministry of Health and Social Welfare issued standardized guidelines for facility-based maternal and perinatal death reviews in 2006, though these had been taking place in some facilities from as early as 1984. During a maternal death audit meeting, the designated healthcare providers and administrators went over the details of women who had died from pregnancy-related causes. The usual participants at Mawingu included the regional medical officer, the medical officer in charge of the hospital, the maternity ward nurse and doctor in charge, all of the district medical officers, the regional and district reproductive and child health coordinators, and representatives from various hospital departments, including the lab, and as well a handful of maternity nurses. So you can see it certainly was a big effort to get all of these people in the same room, in the same place at the same time, which often delayed the meetings. A WHO publication describes the maternal death audit in this way. A maternal death audit is an in-depth systematic review of maternal deaths to delineate their underlying health, social, and other contributory factors, and the lessons learned from such an audit are used in making recommendations to prevent similar future deaths. It is not a process for apportioning blame or shame, but exists to identify and learn lessons from the remediable factors that might save the lives of more mothers in the future. Here you can see an example of an audit form from India. I just took a screenshot of the second and third pages of this very long form. During the audit meetings, the participants also discussed potentially contributing factors extending from the woman's family and community or the referring health facility. And here too, you can see they also look at antenatal care, and this is much more thorough of a form than the ones in Tanzania, but the underlying idea is the same here. So these discussions enable district health administrators to analyze how they can improve the referral system, infrastructure, and communication in the future in order to save more lives. At the end of the discussion of each woman's case, the group agrees on an action plan to be carried out in the ensuing months to address the preventable aspects of the woman's death. These meetings play an important role in collecting data, legitimating state efforts to reduce maternal deaths, and demonstrating the efficacy of individual healthcare institutions. In an era of audit and accountability, of counting and an obsession with metrics as the next global health panacea, the maternal death audit meeting holds a new and loftier role as a way to track these deaths, count them, enumerate the true extent of the problem that is maternal death, and collect data on the ongoing causes of these deaths. Policymakers, governments, and global health practitioners contend that these data, by extension, provide them with the keys to reducing or eliminating such deaths. While the numbers and the forms are meant to strip the dead women's lives down to their clinically important constituent parts, these tools of audit culture are in no way value-free, no matter how much their inventors might wish this to be so. Indicators, just as a country's maternal mortality ratio, such as a country's maternal mortality ratio, are key instruments of governance. As Sally Engle-Mary and colleagues remind us, indicators influence governance when they form the basis for political decision-making, public awareness, and the terms in which problems are conceptualized and solutions imagined. Conversely, the kinds of information embodied in indicators, the forms in which they are produced and disseminated, and how they function as knowledge are all influenced by governance practices. The production of indicators is itself a political process shaped by the power to categorize, count, analyze, and promote a system of knowledge that has effects beyond the producers. In this context, I argue that the audit meetings and their attendant paperwork became a technology specifically of reproductive governance, which the state often enforces through the production and deployment of demographic statistics, such as those tracking birth rates and maternal death. Lynn Morgan and Elizabeth Roberts define reproductive governance as, quote, the mechanisms through which different historical configurations of actors, such as state institutions, churches, donor agencies, and NGOs, use legislative controls, economic inducements, moral injunctions, direct coercion, and ethical incitements to produce, monitor, and control reproductive behaviors and practices, end quote. Often, women are the targets of mechanisms of reproductive governance, but in death audit processes, this complex comes to bear forcefully on administrators and clinicians. The nurses, doctors, and health administrators are at once targets of reproductive governance and tools of these regimes, as they also work to shape women into responsible reproducers through their interactions with them on the ward on a daily basis. The data they produce in these meetings include vast quantities of information, not just about women, but about the data's producers themselves, so the administrators here, and the health system in which they work through what is both present and absent. In this instance, these parties are responsible for facilitating society's social and biological reproduction through preventing the deaths of pregnant women. Meeting participants must carefully negotiate how much they reveal about their own culpability while also meeting bureaucratic requirements, which, if unmet, could trigger other sanctions on the hospital and its leaders. These death audit papers are meant to standardize, but in fact, what they do is strip down, reducing complex lives to yes or no answers, stuffing bodies of mothers and babies into check boxes that cannot possibly contain the messiness and conflicting narratives of lives lived and lost. Bureaucratic documents and development projects generally often seek, after Ferguson, to render technical, complex problems that will then be amenable to technical interventions and solutions. As Tanya Lee observes, quote, to render a set of processes technical and improvable, an arena of intervention must be bounded, mapped, characterized, and documented. The relevant forces and relations must be identified, and a narrative must be devised, connecting the proposed intervention to the problem it will solve, end quote. Maternal death audits and their forms seek to do just that. Yet the vast complexity of people's lives and care practices can never be fully encompassed in these documents, whose very purpose is to reduce, distill, and standardize so that the lessons from them can be presented in terms of these interventions and solutions. Importantly, the form should also comply with global notions of the causes of maternal death. Lost here too in these forms are the true underlying causes of maternal death, including Tanzania's political economy and other drivers of stratified reproduction. The anti-politics machine is hard at work, containing meaningful challenges to the status quo. When I read Form B, the second form of a two-form set sent to the Ministry of Health after each audit meeting, I could discern almost nothing about the course of the woman's illness, how she came to be at the hospital, the context in which she had lived, and ultimately anything about her interactions with the government hospital other than her diagnosis. In Tanzania, despite an emphasis on a qualitative in-depth analysis of each death, the Ministry of Health forms do not provide much space for elaboration of details. Armstrong and colleagues observe that the structured reporting forms are designed to collect mostly medical causes of death and as such are less suitable to guide the team through an analytical discourse on the gaps in service provision, nor stimulate action-oriented dialogue in the forum. This lack of action-oriented dialogue significantly reduces the impact of the meetings, solidifying them as performative rather than functional. Typically, the meeting started with opening remarks from the regional medical officer, the top administrator in the, for health in this area. Then the maternity ward doctor in charge would begin going through the case files. He read through each woman's medical record from start to finish, pausing for questions or comments on her diagnosis or course of treatment, as others present in the meeting asked for clarification. People would point out delays in the care, question the quality of history taking, or ask about the events that had preceded the woman's arrival at the hospital. The first cases received more careful consideration and discussion, with the district level administrators interjecting comments about a facility lower down the referral chain or about how we might determine if the woman had received adequate prenatal care. However, I found, particularly as the meetings dragged on for many hours, the attendees began to focus more and more on simply filling in blanks on the form. This is also the reason why it's supposed to happen at least quarterly, so you don't have 20 cases you're supposed to discuss. As the time went on, they began to copy action plans from one woman's form to the next by rote without any commensurate discussion of the plan's appropriateness. This was also because the meeting's attendees identified similar problems in many of the cases. The metrics of global health have come to have paramount importance, clearly visible in the maternal death reporting structures, but overshadowing or precluding more concerted consideration of the complexity of the lives of individuals and even institutions. Likewise, the discussions about responsibility in clinical decision-making, action plans, and outcome indicators in the audit meetings were never able to tell the whole story. But then again, telling the whole story was not really the purpose of these meetings. Meeting participants distorted the truth for themselves and most certainly for the consumption of higher authorities. Reporting requirements were routinely a challenge for many of the healthcare facilities in Rukwa. In addition to confusion about how to fill in the report in record books or delays in taking these reports to higher levels, reporting could go wrong in any number of ways. In some instances, I became confused about how the hospital was counting deaths and who was supposed to take responsibility for which deaths. In theory, any woman who had died at the hospital was supposed to be counted and documented as a hospital death. This sounded to me like a fairly straightforward black and white system. Either she was alive when she arrived or she was not. However, in practice, there was a much less distinct line. The hospital did not want to appear to be making no progress in improving care and reducing deaths, so they were often selective about how they counted the deaths. This selective counting was an effort to shift responsibility onto other sources and away from the hospital itself. When a woman arrived at the hospital already dead, it became less important to remember the details of her case, to record her passing, or to track the life of her statistics after her death. The hospital workers and administrators were happy to absolve themselves of deaths that were not theirs. In this case, the ethical negotiations of care and work were straightforward. She was clearly not their problem. In mid-2014, I was away from the hospital for about 6 weeks. At the beginning of July, I tried to follow up and collect information on the maternal deaths that had occurred while I was gone. I'd heard there had been 2 or 3. After asking the maternity ward doctor in charge, Dr. Charles, who was unable to give me any information, I went to the nursing supervision office and then went with another nurse in charge of data collection to the outpatient department, or OPD, to speak to the doctors who might have received these women who had died. We went to ask Dr. Salome, one of the main OPD doctors, who told me she remembered one case from April. The woman had arrived from the village, had been treated for pregnancy-induced hypertension, and had gone home to stay with relatives in town. The woman had then developed further problems. Relatives had brought her back to the hospital, but she had died on the way there. Dr. Salome had verified the death dead on arrival. She said she had written it on a piece of paper and sent the body to the mortuary. Technically then, Dr. Salome explained to me, the death didn't occur at the hospital, and the death report was sent to the district from which the woman came to be counted in the records there. For the other deaths, neither Dr. Salome nor the data nurse knew anything else. The data nurse, Lulu, told me I should go back to the maternity ward to check. But I said, they didn't reach maternity to be admitted, so where are these deaths counted? Deaths from where? After 2 more tries for information, I returned to the maternity ward to the start of my search with no further information about these 2 deaths. Samahani, Nurse Kinaya, excuse me, do you know about these deaths that occurred here in May and June? I asked. Where can I find information on what happened or who these women were? In her brusque, matter-of-fact manner, the ward nurse in charge said, "The medical officer in charge knows about them. He's the one who said not to document them because we're increasing deaths that are not ours. It looks like we've killed them, but they came already in a bad condition." That day, I did not receive information about the women's names, their home villages, or any other details that would have made it possible for me to follow up. When I asked Dr. Joseph, the hospital medical officer in charge, he simply explained that they kept no records of such deaths at the hospital because the women had not been alive long enough after arriving to actually be officially admitted. He and others at the hospital with whom I spoke did not feel that the hospital had any responsibility to count these deaths of women who arrived already dead, either literally or figuratively, almost dead in the case of those who expired shortly after arriving. I asked him if there was even a record of the women's names, and he told me no. As the system currently functioned, it was feasible that their names would be impossible to find again, and their deaths might go unrecorded at any level. This experience was another instance that caused me and others to be suspicious of any reported declines in maternal death at the hospital, in the region, or in Tanzania more generally. These accounting moves in the discourse of women arriving already dead served to shift responsibility and accountability outside the hospital. In this way, the providers and administrators were, in an ethical and state-sanctioned manner, able to shrug off these deaths and leave others to worry about their implications. There was no need to increase the work, the numbers, or the emotional burden at the hospital by reporting deaths that had come from elsewhere. In not entering into a relationship with these women as patients or as statistics, the hospital was also refusing them as seekers and recipients of care. The hospital was severing, arguably before the tenuous claim was ever formalized via these admission books and logs, the care connection that would have obliged the nurses, doctors, and administrators to take on a dying woman, and as a result, the statistic of her death. Here, they could hide behind seemingly formalized bureaucratic rules about who constituted an admitted patient of the hospital, and bolstered by the bureaucracy, ethically turn down care for the woman. Denying this care relationship was a way of enacting other care relationships, including care for the maternity ward, for the hospital, and care for the region's reputation on the national level. In one audit late in my stay, we were discussing action plans. We were talking about ways to determine if women were getting enough education during antenatal clinic visits. I pointed out that simply observing dispensary providers during health counseling talks was not a valid way to measure what women were learning at the antenatal clinic. Naturally, I argued, the provider being observed would certainly change their behavior on the day of the visit to appear as favorably as possible. One of the district reproductive and child health coordinators became incensed and accused me of not understanding what it was like in villages and their dispensaries. I politely returned that I had, in fact, spent a great deal of time in villages, and specifically in dispensaries, in 2 different regions of Tanzania. She continued to bluster that I did not know what I was talking about. My more critical reflections and suggestions, though perhaps empirically sound, were definitely unwelcome. I had upset a balance in which meeting participants complied with documentation requirements and an official technologization of maternal mortality, while escaping additional work and new routines, which this resource-poor region would have been unable to adequately support. My foreignness made it easy for the participants to suggest I was unaware of the implications of what I was suggesting, as indeed at the time I was, but not in the ways I'd perceived them to be accusing me of being unaware. I was naively fixated on suggesting methods or action plan steps that might actually have produced valid outcome indicators, but that was not, in fact, the intent of these meetings. I was operating on an entirely different plane, one likely characterized by a privileged positionality derived from growing up in a world in which I could control many outcomes, and in which validity, accuracy, and efficiency were paramount goals. In short, I developed my subjectivity in a landscape very similar to that which had produced the idea of maternal death audits as technical interventions. I was not from the landscape that actually produced most of the world's maternal deaths, so the important performative aspects of these meetings were somewhat lost on me at the time. At Mawingu, changed practices were not necessarily the ultimate goal of these meetings, more because of systemic constraints than because of any real lack of will. But the meetings could be successful in these other, more performative ways. There was often some uncertainty about how the woman's obstetric emergency had unfolded. If the details of her treatment within the hospital were certain, those events that had preceded her arrival were often not very clear. In other instances, the woman arrived at the hospital perfectly healthy, and her death came as a result and as a sudden and unexpected shock, even to the providers involved in her care. While no one ever expected a woman to die, some women arrived at the hospital in obviously poor health, and their decline and subsequent death were consequently less of a surprise to the ward staff members. In one particularly bad week in March 2014, just 1 month after I had arrived at the hospital, several women died within the span of a few days. The most shocking of these deaths was that of Paulina, whose story opens my book. She had reported to the hospital for a scheduled C-section before her labor started. She was in her mid-20s and had had her 2 previous children via C-section, and these prior C-sections were a standard indicator for another surgical delivery. In this case, Paulina had arrived early with plenty of time to prepare and schedule her surgery. It was not an emergency. The next day, Nurse Lucy, who'd been assisting in the operating theater and had gone to receive Paulina's baby when it was born, reported back to us on the ward that Paulina had died. She had needed a blood transfusion, but she was blood type O negative, a rare type compatible only with other O negative blood. There was not enough blood available at the hospital, and Paulina received only 1 unit. In later discussions, the doctors and nurses agreed that her death was likely due to hypovolemic shock from her prolonged internal bleeding. The nurses were dazed, and in the days afterwards, Dr. Deo, who had seen Paulina from the time of her arrival at the hospital, was adamant about implementing changes to procedure to prevent similar deaths in the future. On rounds with Dr. Deo, almost 3 weeks after Paulina's death, he told me, "Now, for all cases of planned, non-emergency seizures, we clinicians must make sure we have the results of the patient's blood type, cross-matching, and hemoglobin tests. We should have 2 units of blood on standby for them too, before even starting the surgery. We must learn from these other cases and not repeat that mistake." To my surprise, when we later, this was now 4 months later almost, discussed Paulina's case in the audit meeting, there was no mention of this proposed protocol, nor did the meeting participants, including Dr. Deo, put this in the action plan. It appeared that once a death lost its immediacy, the nurses, doctors, and administrators quickly returned to the status quo necessitated by their environment. Dr. Deo's ethical negotiations in the aftermath about what should have been done to prevent Paulina's death did not result in any lasting change. Though we reflected on the events and sought to improve outcomes in the future should a similar case occur, the effects of these efforts faded along with the immediacy of Paulina's death. There was little visible follow-up to address the changes that might have reduced future deaths from similar causes for all of these cases they reviewed. In some instances, the doctors explained to me this was because they had started trying to initiate a change or had requested a missing supply, but were swiftly met with barrier after barrier after barrier, or the reluctance of their colleagues, and soon had given up the plan. The hospital's quality improvement team should have also participated in organizing things like on-the-job training to improve skills, as well as following up on the requisitioning of needed supplies. However, during the majority of my time on the maternity ward, the ward's quality improvement team was more of an idea than a functioning body. No one was 100% positive about who the maternity ward representatives were, and it was unclear whether they were actually meeting or implementing any activities. This lack of certainty about who was responsible for following up or for implementing new protocols and guidelines compounded my feeling that the paperwork resulting from maternal death audit meetings was lost in an unknowable bureaucratic quagmire. The amount of bureaucracy constructed at both a national and a local level around systematically measuring maternal deaths, accounting for them, and implementing programs to reduce these deaths would lead one to believe that the outcomes of such efforts would be consistent and replicable declines in pregnancy-related deaths. After all, as Weber tells us, dependable replicability is or was at one time the objective of bureaucracy. Systemization for replicable, predictable, and efficient outcomes, part of rendering this problem technical. However, the outcomes were more often arbitrary, underanalyzed, and lacking causal certainty. Perhaps declines in maternal deaths were due to actions on the part of the healthcare providers and administrators, or, just as likely, any declines were simply a chance occurrence whose continuance into the future was not something that a facility, a region, or the country could depend upon. The outcome of the maternal death audit meeting was supposed to be these action plans I've been mentioning, decided upon by the meeting participants. You can see here an example of a death audit form from Ghana, which includes the recommended actions and timelines and responsible person. The ones used in Tanzania are very similar to this. The underlying premise, once again, right, is that these action plans could structure next steps within the hospital and at the district levels that would prevent reoccurrence of maternal deaths from the same causes. Sometimes the woman's death could have been prevented by the presence of a specific supply or something as easily remedied. More often than not, however, the problems the meeting participants decided to include in the action plan boxes on this last page of the Ministry of Health audit form were not so concrete and self-contained. The needs the meeting participants identified often went along the lines of better education of pregnant women during the antenatal clinic, and the corresponding outcome indicator was left as a decrease in maternal deaths. Not only was it impossible to measure the success of prenatal education in this way, but the plan did not actually delineate specific steps to be taken in order to reach this better education, or identify any intermediate indicators that could demonstrate the plan was on the right track, or give any indication of where the resources to accomplish these plans were supposed to come from within already tight budgets, beyond saying that the person responsible was the district medical officer or the regional medical officer, for instance. This method of creating action plans that the region was incapable of executing mainly served the administrators who would be in the responsible position. With little to no time dedicated to actually producing steps that would lead to accomplishing the action item, and in the absence of the extra staffing with which to execute them effectively, the administrators sitting around the table at the maternal death audit meetings worked within their national reporting structures to fulfill these bureaucratic duties, while also ensuring that they did not generate more work for themselves. This simplification of maternal deaths that reduced them to these impossible action plans was yet another example of the way technical solutions to complex problems and the fetishization of indicators precluded actual solutions, while all the while the actual contributing factors never disappeared. It was this issue of action plans that started me on the road to thinking about these meetings as performance. After the meeting participants completed their action plans, the data traveled only upward. The nurses on the ward, save the few present, who were responsible for everyday care and prevention of these deaths, never received a complete report on the meeting's findings. The lack of feedback and communication about action plans, progress made, or interventions planned amplified the sense that any change in the number of maternal deaths was simply a random occurrence. Perhaps it was luck. Perhaps it was due to different staff members. Perhaps it was due to the weather in the region, as when bad rains caused the roads to deteriorate and delayed a woman's arrival even further. Maternal death audit meetings are another tool that people outside Tanzania have constructed, and that is meant to aid providers and administrators as they work to continue reducing these deaths in their settings. And yet, audit meetings rarely took the ideal form they were meant to have. As the smells of waiting rice, chicken, and chapati from the caterer wafted over to the meeting table, the participants rushed through the details of cases, attempting to rule out a death as related to or caused by pregnancy, and simply advising each other to copy the details of the action plan from previously discussed cases. The administrators, nurses, and doctors sitting around the table seemed to be engaging in a performativity of the meeting as bureaucratic requirement, as opposed to an actual tool for changing their ways of practicing care and serving pregnant mothers. The forms and numbers they produced traveled to higher levels and there turned into other numbers, indicators. As Claire Wendland has commented, an indicator, quote, looks like a number and works like a fact, but it is more like the moral of a story, end quote. It's a moral that hides uncertainty, highlighting some contributing factors while strategically de-emphasizing others. Overall, while the Rukwa region was, on paper, meeting the demands of the Ministry of Health and other organizations for surveillance and reporting of maternal deaths, the fulfilled bureaucratic requirements belie the unsuitability of the maternal death audit system. It's clear that death audits as reproductive governance are not totalizing, and they do not straightforwardly produce new subjects. Instead, these apparently disciplining regimes, here those of maternal health indicators and global safe motherhood, quote, retain resilience, unpredictability, and are shaped by effects of local and biological specifics. To what extent have tools of governance like the maternal death audit meeting shaped new subjectivities? Or in what ways have the simplifications inherent in this globally mobile exercise rooted in public health left open a space for healthcare workers and administrators to resist their reformation as self-disciplining subjects in this global complex around ensuring safe motherhood? Staff do not actively want to resist the reduction of maternal deaths in their setting, but the forms and bureaucratic processes to which they are subjected ignore the locally specific spaces in which complex practices of technical and affective care, informal accountability, and clinical improvisation grow, and are utterly unable to capture them. What this process reveals are the contributors to maternal death already well known and amenable to technical solutions, proving perhaps that the audits work perfectly. Likewise, the expectations inherent in the forms and rhetorical processes of the audit elide the region's pervasive lack of resources, which is one of the key contributors to the failure of so many potential and attempted interventions. Perhaps the administrators' resistance to the reproductive governance trained on them takes the form of engaging in a performance of the audit meeting that rarely goes deeper than that, because they are aware that the expected action plans following a narrow script are unsuited to and often impossible in their setting. What this means is that every subsequent meeting will see the emergence of the same barriers, the same challenges, gaps, and pitfalls as have repeatedly been identified in the past. Those problems amenable to technical interventions will make their way into action plans, while the deeper roots of maternal mortality, both in the hospital and in the community, will remain unacknowledged and unaddressed. Inequity and resource scarcity remain tenaciously entrenched, escaping technical rendering in this audit process. So much of the proceeding is from chapter 6, entitled "The Stories We Tell About the Deaths We See," from the book. And in addition to calling attention to this performative nature of death audit meetings, I hope it also encourages us to think creatively about how we might construct new systems that work better in places like Tanzania. I hope you also got just a little preview of some of the other themes in the book, including things like care and this idea of everyday ethical negotiations. Just as a sort of note of interest, after I completed this field work in the end of 2015, the Ministry of Health updated the whole audit process for deaths and came out with new forms. And so I've not had any occasion to participate in one of these meetings since that time, but I have helped fill out the new forms for neonatal deaths, actually. So that is the end, and thank you everyone for coming. And I have some adorable babies here, but we'll stop sharing my screen so we can take some questions if there are any.
Thanks, Adrienne. If anyone has a question or comment, please raise your hand and I'll call on you. Okay, you have one from Kate Robbins. Go ahead, Kate.
I unmuted now.
Yes.
Yeah, what came to my mind toward the end of your talk was the situation we have in the United States, where there's now a great deal of concern expressed verbally and in print about maternal mortality particularly among minority women, Black women in particular. And I wondered whether someone shouldn't be looking at hospitals here, because I suspect that a lot of the performative bureaucratic routines that you've identified in Tanzania may actually be taking place here, might even have been modeled on things that are being done here that are similarly ineffective in pushing the needle on this critical issue, and whether there isn't a whole sort of layer of reality underneath that. I mean, the story that's always repeated, and it's like many stories, it's effective, but it doesn't, necessarily give you a view of everything that's going on, was, what happened when Serena Williams delivered in a small hospital in South Florida and almost died in the process.
Yeah, I think that I certainly see a lot of similarities in terms of the bureaucracy, though of course in the US that's a lot more technologically advanced, which I think often maybe makes us think it's better. But I certainly think some of the underlying principles are still problematic across settings. And there are some really excellent anthropologists working in the US on this issue of disparities in maternal mortality, particularly with Black women. And several of those people are doing really amazing collaborative work with obstetrician gynecologists and really trying to pioneer both new sort of theoretical frameworks for us to work with. One of them that Donna Ayin Davis has come up with is obstetric racism. And she's been working with in OBGYN out in California to design this whole program to recruit Black women into this cohort to get their experiences and collaboratively design with them new ways to train healthcare providers and work with them to improve care for minority populations in obstetric care in hospitals in the US.
Thank you. You have another question from Elizabeth Rios. Go ahead, Elizabeth.
Hi, Dr. Strong. Thank you so much for your presentation. It was definitely really, really interesting. I kind of had a question about ethics, and it sounded like, at times you tried to speak up to the doctors and nurses, and they kind of disregarded your comments. And I was just wondering, how did you negotiate, speaking up or not? I can just imagine how frustrating it must have been for you to be there and to watch, so many women die.
So I shortened that story about the interaction with the district reproductive and child health coordinator. There was more that went on there, and one of the doctors on the maternity ward who knew me a lot better, I told him afterwards I shouldn't have said anything, I was out of line or it wasn't my place or whatever, and he said, no, she just got so upset because she knew you were right. And I was like, well, I don't know, that was a whole weird exchange, right? Which is what led me to think about that particular exchange a lot more later. But it was a careful balance at times of saying things and also just not saying things, right? Which becomes sometimes ethically very fraught when you are witness to problems like negligence or neglect, or worse, sometimes there were instances in which I knew exactly what had gone wrong in a woman's case, and her family was really upset, and the healthcare providers closed ranks and wouldn't say anything. And it was not, I didn't view it as my place to be the one to speak out for a variety of reasons. So a lot of that is what I had to grapple with on my own as being part of working in this environment, and as part of the sort of cost of having access to this environment. But it's really complicated, and I think that there are not really good answers to what should be done at exactly what moment and by what mechanisms. And there were people, administrators at the hospital who also knew that things were going wrong, and they actually, because of really complicated bureaucratic procedures, were unable to discipline staff members. And so it wasn't like I was the only one who was sitting there unable to make things change, sort of a fact of the system, unfortunately. I don't know, that's not a great answer, maybe, Elizabeth, but hopefully that gives you a little more insight. There were times, honestly, where I just had to walk away from things because I knew if I stayed, I would yell at someone or get angry in a way that would jeopardize my ability to keep going back there. And basically being able to get this information was really founded on the relationships of trust that I built with the nurses and the doctors and the administrators. So I couldn't jeopardize that, because I think in the end, I hope that being able to do this analysis and to see how this played out and be able to talk about it will help many women in many places in the long run. So it's a sort of a ugly trade-off at times, maybe. I don't know.
Thank you.
Okay, next question from Megan Cogburn. Megan, go ahead.
Hey, hi Adrienne. Thanks for your talk. I'm really looking forward to reading the whole book, but I might have a question. It's just kind of like a simple question, but one that occurred to me when you were talking about the maternal death audit meetings. I'm wondering if you can discuss a little more, you had that list of all the participants that are meant to be in those meetings, which I can imagine it's very difficult to get all of those people together in one room. But I'm wondering about what they thought of the meetings, or what, if you had any sort of longer conversations or interviews with any of those kind of key participants, what they thought, or how they discussed the, thought of actually the meetings themselves.
So the one person who I probably talked to the most about this was one of the nurse midwives. She had in the past, several years prior to when I was doing this work, been a district reproductive and child health coordinator. So had not only participated in these meetings, but had also been responsible for making sure that data was collected and reported from her district. And she thought they were really important, the meetings, and was like very upset that they were often so long delayed, but didn't really have, we didn't talk so much about like the role overall of these meetings. And most people did not, we didn't have conversations about that, unfortunately. I think it would be a really interesting thing to ask people about now, particularly as I've thought a lot more about these things. At the time, it was just like a given, it seemed like just a given part of this is another meeting that happens. And it happened at I never was told, no one ever had an answer as to whether or not this was also conducted at the district levels, because in theory, we were only talking about the deaths that occurred at the hospital. And the only reason all these other district and regional officials were present was because it's a regional hospital. So top of the referral chain, and therefore other people might be involved in terms of making sure that lower level facilities were doing the right thing. But no one ever reported a meeting of this nature occurring in the districts. So there are also clear sort of gaps or places at which this did not ever occur, and nobody seemed particularly bothered by that. But at the hospital, it was like everybody has to be there in the same room in order to do this thing. And that was often used also as an excuse for delaying it, right? But yeah, that would be an interesting question to talk to people more about, Megan.
Okay, you have another question from Caitlin Parente. Go ahead, Caitlin.
Hi, thank you, Dr. Strong. This might be out of the scope of what you were researching there, but did you notice any obvious trends or underlying social factors that were neglected because of these maternal death audit meetings that kind of seemed to diffuse responsibility? Was there anything that you observed that was just being ignored because of the metric that they were using there?
So I think the worst thing, the thing I might hate the most about the format of these forms, at least the ones that were used at the time, I'm not sure if they've changed, but they follow this like public health 3 delays model of care. So the first is like delays in the family, and then it's like in making a decision in the first place that you need to seek care. And then the second one is delays reaching care. And then the third one is delays in receiving appropriate care in the facility. And so it was very easy for them to say that there had been a first or second delay. A lot of times there were interesting ways in which they tried to manipulate information or sort of interpret missing data to suggest that it had been the woman's fault or her family's fault that she hadn't arrived somewhere earlier. And I really don't think in most cases that wasn't really the defining factor here. And there was also, which I talk about later in the book, the chapter after where this material comes from, I talk more about this idea of being already dead. And so actually, like, they were telling me that these women are coming from like the far reaches of the region, and everybody starts with traditional birth attendants, which delay them at home, which is also not true. But this is a way of sort of demonizing like any desire or other factors that lead people to have births out at home outside facilities. But in fact, people were not coming. The people who died, the women who died, were largely not coming from the furthest reaches of the region. I think almost half of the deaths that, I think it's something like 17 or 18 out of 34 that happened while I was there, were of women who listed their residence within the urban district, which was the district immediately surrounding the hospital. So I interpret that as sort of a way of saying, this is not, if they're coming from far, far away and they're coming mostly dead already, there's nothing we can do about it, right? And that was, I think, sort of a social function of the hospital and the providers, as I mentioned, sort of trying to shift blame to other factors that were outside of their own control, which I think is also sort of a protective coping mechanism. And like the audit process cannot pick up on things like that, right?
Yeah, thank you.
Just a couple examples, yeah.
Okay, does anyone else have a question or comment in the room? Megan, you have another one, go ahead.
Okay. Yes. Okay. So one more question. So I'm curious as to, the language about women arriving already dead and kind of like this classification. I'm curious as to what would be classified in terms or the reporting or the records. Would these types of births or deliveries be counted or classified as home deliveries or like births on the way? Or what did you see related to that kind of, because I guess on the one hand, right, you have this classification related to like a woman coming, being already dead, but then you have where was this woman? Where did she deliver?
Yeah, so most of these people were not delivered before they arrived because either something like obstructed, we're talking, right, grievous, like seriously life-threatening problems. So things like obstructed labor leading to ruptured uterus, or something like postpartum hemorrhaging. So there were people who had already delivered elsewhere and came back because of hemorrhaging, later retained placenta occasionally. And there were times where these people were referred from other facilities or had given birth maybe at home beforehand, but the hospital was not seeing them for the delivery, right? And then in these other cases, they were had not delivered yet. So either it was like before the birth and therefore not really the hospital's problem, or it was like she was there because she had not yet delivered. And I'm trying to think, in the few instances in which she arrived at the hospital after having already given birth, if it was clear from her record, if the information was available that, she had given birth at home, then it was discussed in in the meeting, but sometimes they also didn't really have that information if they were missing that part and couldn't get it from relatives or things like that. But in terms of anything like fines or disciplining women in any way for those things, that was more of like a district problem and not a hospital problem. So it came up, but it was oftentimes, I would say a lot of them either hadn't yet given birth and were there because of something like obstructed labor, or yeah, had given birth sometimes even well before, and the hospital was not concerned. Does that answer your question?
Yes, I think, yeah.
Yeah, I mean, so it was like, it was a different issue than like in villages, at health centers or at village dispensaries. People were much more fixated on like whether or not the birth had happened before reaching the facility or on the way or at home or wherever. And at the hospital, it was in these sorts of instances, because the emergency was so severe, right? It was not really what people were fixated on. Like there were other more important factors in the conversations.
Right. No, that makes sense. I see those things as, I think at like the district level hospital, they're somewhat maybe more linked. And there were some audit meetings that occurred at the district level hospital I was at, but I wasn't able to attend those. But yeah.
Yeah, and I think it's interesting too, what I still never really got an answer about, right, is like maybe at the district level hospitals are doing it, but I was in the region where I worked, there was only one district hospital that was like fully functioning as such, and the other districts didn't have hospitals. And so then it's unclear to me, like if the death didn't occur in a district hospital, was it being audited somewhere else? So those deaths, like if she died at home, for instance, did anybody ever discuss that?
I think yes, but we can let them.
I mean, yeah, I mean, where you work, you know, maybe, and if so, that's great. I just never heard, I could never get like a clear answer on the rules for that in Rukwa.
Okay, anyone else with a question or comment?
All right, well, thank you, everybody.
Yes, thank you, Adrienne.